they're marketing for is perfect for what most people need it for in the ASC. So I think the other thing to consider about this disposable system is the cost. Now, as many of the people listening to this podcast know, whenever we start talking about disposable scopes, we start talking about cost. We start talking about money that needs to be spent by a hospital or an ASC. And that's not an insignificant burden to the system, the healthcare system, the insurance company, and in many cases to the patient, though it is a lot of money. So the one of the many great things that EndoSound has done, they have actually worked with a team of people who have experience in healthcare policy, and they've gone to CMS, and they've actually, just as of July 1st, gotten a pass-through code approved. For those of you who don't know, a pass-through code is a code that you submit to Medicare when you use a device, and then Medicare reimburses for the cost of what you paid for the device. So the pass-through code that they're going to use, if I'm not mistaken, C1602, we may need to fact check that. But that is a code that would be added on. So I'm going to kind of go back a little bit and talk about the finances of EUS and specific to the ASC. I have a much more in-depth conversation on that on my other podcast, but just in a private ASC, you want them to generate some profit. Even if it's $10, they need to generate some profit. So something like this actually allows you to do that. Now, let's kind of walk through the numbers. So $832 is the Medicare reimbursement. So if you use EndoSound, again, depending on agreements, but list, you're paying $650 to do this. So if your cost per case is already $250, you add $650, that's $900, right? Yeah, and you're only making $832. So that's not feasible. But with the pass-through code, what happens is you bill the insurance or the Medicare $832. Again, national average, it might be a little bit more or less in your hometown. But you bill that $832, and then you add the pass-through code, which you have to support with documentation of what you paid the company. So you paid $650. You show them the receipts, basically. And so now you send a bill to Medicare for $832 plus $650, $1,482, I think. And you would be reimbursed the cost, the $650, plus you would be reimbursed for your procedure. Where that helps an ASC out a lot is, number one, you're not having to pay for a fixed system. So again, if you buy a fixed system at $250,000, well, you have to pay that $250,000 with each case, meaning that the break-even point for most procedures, most EUS systems, is about 350 to 450 cases a year. So you're paying that, but that's added to your, let's say your cost per procedure for a colonoscopy or EGD is $250. Well, then you have to add the cost of the needle, and you have to add the cost of the purchase of the capital equipment, the scopes and the processors to that. The beauty of this EndoSound pass-through code is that you actually now have the ability to actually charge the insurance company for something that the patient needs. And some naysayers may say, well, we're just increasing the cost in the ASC, but you're still way cheaper than the hospital. $832 at the ASC equals about $1,700 at the hospital. ASCs generally are more bundled, so everything has to be done at that $832. The cost of their IVs, your nurses, your fluids, all that stuff. Hospital actually has the ability, and most of them do this, some don't, to charge for each and every component. They're going to charge for the nursing time. They're going to charge for the fluids. If you give them the lactate ringer, they're going to charge for that. So all that adds up in an EOB, or explanation of benefits, that many people get after a procedure at the hospital for EUS FNA, probably close to 10 grand, And an ASC, the bill will say exactly $832. There's some numbers that people will add to it to show a loss and a write-off to insurance, but essentially what you're billing, what you're paid is the same. So and everything has to be covered at $832. So this provides a mechanism for someone to be able to actually invest in a technology and use it on their patients and make their lives better, but then not have to break the bank and actually get reimbursed for it. So this is a huge thing that I think is going to be a game changer for EUS in the ASC. For many, many years, when we did our first abstract around 2013 and 14 at the ACG meeting in Philadelphia about the feasibility of EUS and ASC. And a lot of people showed interest, but it didn't take off, and primarily because of the cost issue. This is a way to actually allow that to happen. There are more and more of us therapeutic endoscopists being trained each year. Everybody is told by their mentors that you need to seek out a position in academia, and a lot of people are happy to do that. But the vast majority of physicians don't want to be in academia, number one. And number two, with the number of graduates that are coming out in therapeutic endoscopy every year, truth be told, there's not enough jobs in academia to support the number of graduates. So many of these physicians who are getting excellent training, who are, talented, very talented in EUS and interventional procedures, are being put in an environment where they can't really maximize their partnership in an ASC or in a private practice.